Hey winners. Hello, how are you all doing? I hope you are too much into your preparation now. So to boost up your preparation, we have it another live session with an interesting topic, a very high yielding topic in our NEET MDS, that is our space maintenance. So I hope you all ready for it. So please send me a thumbs up if you all ready to engage in the today's session. And also to have continuous streaming and to get more updates on our YouTube channel, please do subscribe and hit the bell icon for notifications. So are we ready for today's session? Yes, guys? Okay, then all right. So I'll be looking at your comments also. So please let it be an interactive session. All right. So space maintenance, where have you heard it? So do you think it's just a textbook concept? No, it's a cornerstone in pediatric dentistry and also orthodontic clinical practice. So why we are today more focused on learning the space maintenance? Because very frequently this is asked topic, very tricky because I know you all are very familiar with the names of the space maintainers. All right. But I guess when a clinical based scenario is asked, it is very difficult to analyze the situation and choose the right appliance at the right clinical scenario. All right. So for that, we are going to now discuss. So you are all ready for it? So live clinical based or case based scenarios we are going to discuss. So you all have to step up, analyze each situation, crack the case and give me the right appliance of choice for that particular patient. So now you're the clinician and you're going to answer me the questions. All right. So let's go on with the first question today. So here comes our first case-based scenario. So buckle up guys. I want all to be interactive and answer me this question. So let's start. Okay. A 5-year-old child comes to your clinic after traumatic extraction of lower left first primary molar. That is 7-4. Alright. So the child is otherwise healthy and the adjacent teeth are caries free and fully erupted. Okay. And the parents are concerned about maintaining the proper space for the permanent successor. So which of the following is the most appropriate space maintainer for this patient? So that is the question given to us. All right. Hope you all understood the question. And the options that are given to us are distal chew space maintainer, band and loop space maintainer, lingual holding arch, and the final option is removable partial denture. So this is how you need to. So this is the case-based scenario that is given to us now. So let's crack it. Come up with the answers. So when a case-based scenario like this is asked, so how you are going to tackle this? First, there are some key points that you need to note in the questions. All right. So the first key point is the age of the child that is given in your first line itself. All right. So here is the first thing. It's a 5-year-old child. Okay. So that is the first point we need to make a note. Then the second point, how many teeth are missing? Okay, single tooth is missing, multiple tooth are missing, there is a unilateral loss or a bilateral loss. This is what we need to make a note. So they have clearly mentioned that the lower left first primary molar, that is a 7-4 is missing. Okay, so only one tooth, that is 7-4 is missing. It was extracted. Alright. Then the child is otherwise healthy and adjacent teeth are caries free. That is the third point you need to note about the abutment teeth. The adjacent teeth you need to maintain. Then the parents are more concerned about maintaining the space. That's what they have told. Alright. So all this keeping in mind, we have 4 points. That is the age of the child and how many teeth are lost and which arch. Is it maxilla or mandible? They are clearly mentioned it's mandible. Alright. Then how are the abutment teeth? So this all we need to keep in mind. The 4 points. So based on this 4 points, you need to answer me which space maintainer we need to give to this particular patient. So guys, come on, answer me. Okay, here comes our answers. I'm checking the comment box. So please do answer. 4 important points we have. Yeah, here comes the answer for you all. I hope you all understood the case. It's very clear. There is single tooth loss in mandibular arch and the adjacent tooth are all present. Yes, the answer would be a band and loop space maintainer. So band and loop space maintainer is the space maintainer of choice in this particular clinical based scenario. So let's discuss about the band and loop. So here it is. So band and loop space maintainer, the main indication of this space maintainer is whenever there is a single tooth loss in the posterior segment of either maxilla or mandible. So whenever there is a premature loss of one teeth, either right side or left side, any side, both in maxilla and mandible, this appliance is the best choice. Okay, so let's decode the design of this appliance. So we have a band that is placed on the abutment teeth and a loop that is spanning the edentulous area. So that is why this is called band and loop space maintainer. All right. So one more important MCQ that can be asked is, where should this loop rest? So come on, tell me, where should the loop rest? Hey guys, there was a technical glitch. I suppose we'll get back to you in a couple of minutes. All right. Okay, we are back. All right. So we are discussing about band and loop space maintainer, right? So band and loop space maintainer, the indication of band and loop space maintainer is whenever there is premature loss of single posterior teeth either in maxilla or in the mandibular arch. All right. So here we are discussing about the design of band and loop. So band is placed in the abutment tooth that is distal to the edentulous space, and there on the edentulous area there is a loop that is spanning. I've already told you, and the end of the loop is touching the teeth that is mesial to the edentulous area. So there is an MCQ that is frequently asked. I need you to answer me, where does the loop rest on the abutment tooth? Exactly at what point the loop should contact the abutment teeth? So that is the question for you. I'll be looking in the comment box for some good answers from you all. Okay. So the contact point of this loop is just above the contact area of the abutment teeth. So wherever the loop is resting, it should be above the contact area, above the height of contour. Alright, so this is all about band and loop space maintainer, which is a very simple appliance which can be used in both the arches, that is maxilla and mandible. Alright, I hope you all understood the clinical rationale behind using band and loop. Alright. So let's get into the next case-based scenario here. So here comes our next case. So a 8.5-year-old patient presents with premature bilateral loss of mandibular primary first and second molars due to caries. Okay. The permanent incisors are fully erupted and the first permanent molars are in place. Okay. So which of the following is the most appropriate space maintainer to use in this case? So this was the question that I am posing you. Okay. And the options given are Nance palatal arch, band and loop space maintainer, distal shoe maintainer, and lingual arch. So these are the four options. So as I've told you, whenever case-based question in space maintenance is asked, you need to analyze one by one. So what is the information that is given in the question? We need to make the points. So come on, start answering me. So here I have given a case of some 5 lines, but you need to analyze one by one, get the information, extract the information from the question, and then look at the answers and select the most appropriate one. The answer is right in front of you. So you need to tell me which is the most appropriate answer. So Joel, I'll help you to shed some light into the question, okay? So first is the age of the patient I have told you. So here we have an 8.5-year-old child, okay? Then how many teeth are lost? That is the second step that we need to know, right? So they have clearly mentioned there is bilateral loss of mandibular primary first and also the second molars. So by this FDI notation, what are the teeth that are missing? So mandibular arch on both the sides, first and second molars are, we have extracted or they are lost due to caries. That means our 7475 and 8485, all the 4 primary molars are lost. So that makes us 4 teeth are missing. Alright, then the permanent incisors have fully erupted and also the first permanent molars are also erupted. That is our third point that we need to note. So based on this clinical scenario to this 8.5-year-old child, which space maintainer you are going to give? As you all rightly answering, the space maintainer of choice in this clinical based scenario is nothing but our lingual arch space maintainer. So you all have answered it correct. So now let's get into the design of the lingual arch and what are its indications. So here is our lingual arch space maintainer, as you all can see. So I told you it is a bilateral appliance, right? So it crosses the midline on both the sides, the wire component you can see. So we have 2 abutment teeth where bands are placed, 1 and 2. Alright, so we need 2 strong molar teeth as abutments to place our molar bands. And we have a wire component that is spanning the entire arch. And the picture of here is mandible, right? So this is a mandibular appliance. This appliance is not indicated or not usually done in case of a maxilla. So it is strictly a mandibular or a lower arch appliance. Alright. So here the entire wire component is spanning the arch. And the contact anteriorly is the lingual surface of incisors. Alright. So lingual surface of incisors is where anteriorly the wire should rest. So in question, there is clear mentioning something about the eruption of the incisors, right? So that line is very important because without the eruption of this incisors, the permanent incisors, this appliance is contraindicated. We can't give this appliance without the support of our anterior permanent incisors of mandibular arch. So I hope you all can understand this. So this is a bilateral fixed passive appliance. Okay, that can be indicated when there is premature loss of multiple posterior teeth in the mandibular arch, either unilaterally or bilaterally. Okay, so when there is unilaterally multiple teeth are lost or bilaterally also multiple teeth are lost and your permanent incisors are in place, then your appliance of choice is lingual arch. I hope you all got it. Okay, so this is all about lingual arch. Now I'll give you one more case-based scenario which is a bit tricky. I hope you all will answer this right. So here I have a 6.5-year-old patient with bilateral loss of mandibular primary first molars due to caries. So my 7, 4 and 8, 4 are missing. The permanent incisors and first permanent molars have not fully erupted in its place. So there is no eruption because he's just 6.5 years. So we have a little more period to anticipate for our permanent incisors and also permanent molars. All right. So what is the appropriate space maintainer of choice in this case? This was the question. All right. So the answer, the options we have Nance palatal arch, we have bilateral band and loop space maintainer, distal shoe appliance or a lingual arch space maintainer. So what do you think? Which appliance is the appropriate one in this case? So slowly decode each line. I know it's a very big question, 3 to 4 lines, but slowly try to analyze each line. Grab the points which are required for selection of our appliance. One is age, how many teeth are missing, and what is the status of our abutment teeth. So this is all we need to assess. Okay, all right. The answers are flowing in. So what is the right answer? I'll be revealing in a minute. So 6.5-year-old child is waiting for you to give him appropriate appliance so that the future malocclusion can be prevented. All right. So that is the main purpose, right? Space maintenance are for maintaining space. The name itself suggests. It's nothing but a removable or a fixed appliance that preserves the space whenever there is premature loss of primary teeth. So see, primary teeth are really important. You need to take care of them too. Otherwise, you have to face consequences. Okay. Coming back to our question. So we have bilateral loss, 7, 4 and 8, 4 are missing. And the permanent incisors and even the first molars have not erupted. So the appliance of choice is, as you have rightly mentioned, it is bilateral band and loop space maintainer. So I've clearly mention, even though there are more teeth that are lost bilaterally or unilaterally, whenever the lower incisors are not in place, lingual arch cannot be given. There's some modifications which can be, but not with the eruption of even one permanent incisor is not erupted, lingual arch can't provide support. Alright, then in that case, we'll go for bilateral band and loop space maintainer. I hope you all understood this concept. So whenever there is in the mandibular arch, there is unilateral or bilateral loss of multiple teeth prior to the eruption of the permanent incisors, then the answer would be our band and loop. Whereas after the eruption of our permanent incisors, then the answer we'll go for is our lingual arch space maintainer, right? Okay, shall I decode the next case? Ready for it? Okay, here comes the next case. A 7-year-old child. So here is the age of the child. 7-year-old comes after premature loss of upper first and second primary molars. So here the case is about the maxillary teeth. So here they have mentioned the FDA tooth numbering also. 5455 and 6465 are missing totally. So the first permanent molars have erupted, and the goal is to prevent the mesial drift of first permanent molars and also maintain the arch width. Okay, which space maintainer is most appropriate in this scenario? So this is the question that was asked to you, and the options given are band and loop, Nance palatal arch, lingual arch, and removable partial denture. So come on now, you tell me which is the most appropriate space maintainer for this case. I hope you are doing that analysis which I have told you step by step. The age of the child, I have already underlined it. Which arch, maxilla or mandible, it is maxilla, and how many teeth are lost? All the primary molars again. Pocket, all the molars are lost. Then the first molars have erupted. So we have a good strong anchorage to place any appliance, right? So main goal is we have to prevent this mesial drift because there is a lot of space. And also we have to maintain the arch width till the premolars erupt in their positions. So which space maintainer is the most appropriate one in the given options? So that is our case for now. So keep the answers coming. And yes, so I'm very happy to see all the right answers here. So the appliance of choice is Nance palatal arch. Okay, so that is the appliance of choice now. So let's decode the design of Nance palatal arch. Whenever image-based questions can also be asked in space maintainer. So whenever I'm showing the design, please try to incorporate what are the wire components and where they are spanning so that you can quickly answer the image-based questions too. And Nance palatal arch is very easy to identify amongst all the space maintainers, right? Because the unique feature is it has a acrylic portion that is resting on the anterior palate, approximating the permanent incisor teeth. Okay, so in the midline, we have an acrylic button. So that is our Nance palatal arch, which is again a bilateral appliance, as you all can see, fixed. And the main important thing to note is it is only given in the maxilla because we need the palatal wall support, right? The acrylic button is resting there. So here is given only in the maxilla. All right. So here we are taking two abutments again, and the wire is spanning the entire length of the maxilla, and there is an acrylic button that is approximating the anterior palate. So this is our Nance palatal arch. It is also called as Nance holding arch also. All right. So the main indication of Nance palatal arch is whenever there is multiple posterior teeth loss, either unilaterally or bilaterally in case of your maxilla. Okay, if the same case scenario is in the mandible, then your answer should be lingual arch. Multiple teeth loss, lower arch, then it is lingual arch. Whereas multiple teeth loss, either unilateral or bilateral, it is in the maxilla, and the first permanent molars have already in their places, then our answer should go for Nance palatal arch or Nance holding arch. I hope you all are clear with this concept. So here is the design of our Nance palatal arch. So the main indication of this space maintainer is whenever the first permanent molar are intact and erupted, and the first primary molars, first or second primary molars on one side or both the sides are prematurely lost, then we'll go for this Nance palatal arch. Okay, so let's get on to the next one. So till now we have discussed about band and loop. We have discussed about lingual arch, and our third appliance is our Nance palatal arch. So all the three appliances I hope you all are very clear and familiar with now, even for the diagram based questions. So let's move on to the next case scenario. So here is the next one. A 7.5-year-old patient presents with loss of maxillary left primary canine, first molar and second molar. There's so many teeth that are lost now. Okay. The first permanent molars are erupted and you need to maintain transverse width and prevent the molar rotation. Okay. So which appliance is most suitable in this particular case scenario? And the options you have are band and loop, Nance palatal arch, transpalatal arch, and removable partial denture. So these are your options. So please in the comment box let me know the appropriate answer you think for this case. So buckle up guys, start analyzing. I'm going to test your critical thinking now. So I know most of you will be confused between the two space maintainers if I am not wrong. So which one is the most appropriate one among them? So keep guessing. Till then I'll shed a little light on the question. So age of the child, we have 7.5 years old. All right. Then how many teeth are lost? First of all, which arch? It's maxilla. That is upper arch. And then how many teeth are lost? There are so many. Primary canines are lost. And first molar is lost. And also second molar is lost. Only on one side. Only left side they are telling. Okay. So left side we have 6.3, 6.4 and 6.5 are lost. Right? According to the question. And the first permanent molars have erupted on both the sides they are saying. And now we need to maintain that space. And the kid is only 7.5 years. So we have more time to see the eruption of the premolars and also the canine. Right? So which space maintainer might be the appropriate choice? So I think there is a clash between Nance palatal arch and transpalatal arch in the crowd. Am I right? So which one might be the most appropriate space maintainer to be given to this child? So here we go with the answer. Transpalatal arch is the right answer for this case. So why? I'll show you the design of transpalatal arch so that you will understand it way better. As you can see, this is our transpalatal arch, which is a bilateral fixed appliance again. But can you note a U-loop here? This is an active appliance. Unlike other space meters we have seen now, they are passive appliances. They will not create any tooth movement as such. But here it's an active appliance where U-loop is incorporated. Okay. So the main function of transpalatal arch is to maintain the arch width. Whenever multiple teeth are lost on one side and the other side of the arch is intact. When one side of the arch is intact and other side there are multiple primary teeth that are lost and permanent molars have erupted in their places, then to maintain that arch width, the space maintainer of choice would be our transpalatal arch. So minor tooth movements, that is derotation of the molars, can also be done with transpalatal arch. Okay. So this is about transpalatal arch, which is a bilateral fixed active appliance. So whenever you want a minor tooth movement, you can activate the U-loop that is given. Okay, in the posterior part of the palate where it is resting. So we can activate it and create some minor tooth adjustments also of the molars. So the main indication of transpalatal arch, when one side of the arch is intact, only the other side there is loss of multiple teeth. Whereas whenever there is loss of teeth on both the sides, then the space maintainer of choice would be our transpalatal arch, no doubt. But when there are multiple teeth are lost on one side and one side it is good, to maintain that width, we will go for transpalatal arch. And also in case the molar has drifted mesially, in order to derotate it also, the appliance of choice would be our transpalatal arch. So hope you all clear with this. So we are done with band and loop, lingual arch, Nance palatal arch and transpalatal arch. So 4 appliances, any case, I hope you will crack it. Okay. So let's get into the next one. It's an interesting one though. So here we have a 6-year-old child who reports to the pediatric dental clinic with pain and gross decay in the lower right primary second molar. So that is our 8.5. The clinical and the radiographic examination reveal a non-restorable tooth with periapical involvement. So what can be done? Now it is non-restorable, they are saying, and there is periapical involvement. And this child is only 6 years old. The maxillary first permanent molars have not yet erupted. Okay. Considering both the dental development and occlusal guidance, which of the following is the most appropriate intervention post extraction? As we all understood, it's non-restorable. We are going to extract 8.5. Right. So, and the permanent molar have not erupted yet. The permanent first molar is yet to erupt. We are anticipating now at the age of 6, right? So, which can be the appropriate intervention they have asked? So, let's see the options first. So, fabrication of lingual arch for bilateral space maintenance. Then, placement of a distal shoe appliance for eruption guidance. Then, defer appliance therapy until the eruption of the first permanent molar. Then, immediate referral for interceptive fixed appliance therapy. So, these are our options. So, a bit tricky question, I feel, to evaluate all the options, to read all the options here. I hope it is visible. So here comes our case. Now you need to tell me, decode. There are 5 to 6 lines to this question. Decode them, analyze each option. Don't jump into conclusion. So one teeth is lost, this tooth didn't come. No. So analyze each and every option, what they have told, and then choose the appropriate option. All right. So 6-year-old, I'll decode it for you. 6-year-old here, and it is in the mandible. Only one tooth is lost, that is our 8.5 is lost, and then we are extracting it. So that is lost, and our first permanent molar, which is supposed to erupt at the age of 6 to 7 years, have not erupted yet. Okay, radiographically we confirmed it. Now what appliance could be given so that we'll maintain the space, and also it will help the first permanent molar to erupt properly in its position. So this is the clue I am giving you. We have to maintain the space that is due to the loss of this primary second molar, and also we need to guide the permanent first molar also in its own place, right? So which might be the appropriate intervention? So that is our question. So I hope, yes, already you're giving me the answers. So the right appliance of choice, so the right intervention of choice in this case would be our placement of a distal shoe appliance for eruption guidance. Okay. So lingual arch, how can we, already the one side there's molar lost, and also the first permanent molars are not in place. So we need to guide the eruption also. So lingual arch is not the appropriate treatment here. We can't defer the appliance therapy because whenever there is an edentulous space, there is always tendency of the tooth to drift mesially. So that is also there. And then immediate referral to interceptive fixed appliance therapy, that also we can't do. We need to, first prevent the malocclusion from happening, right? We need to guide the first permanent molar in its place. So the best therapy that we can follow is the distal shoe. All right. So here comes our distal shoe appliance, which is the unique of all the space maintainers. Okay. So all the space maintainers, they're resting above the gingiva, if you can see the designs. But this is the only appliance, the only space maintainer which has an intragingival extension also, as you can see here. Okay, in the radiograph, there is an intragingival extension or intraalveolar extension. Okay, so that is the reason distal shoe is also known as intraalveolar appliance, or it is guiding the eruption of the first permanent teeth. Not only it is spanning the space or protecting the space for the coming premolar, it is also guiding our first permanent molar to come its place. Okay, so this is also known as eruption guidance appliance. All right, so there are 2 other names for distal shoe. Even when they are in the options, you need to choose them, right? Intraalveolar appliance, or it can be also called as eruption guidance appliance. So here, this appliance, we have a band here that is placed on the abutment teeth, and we have a horizontal arm and a vertical arm. I hope you all can appreciate there are 2 parts. There's a horizontal arm which is spanning the edentulous area, and there is a vertical bar kind of extension that is extending into the alveolus. That is the reason it is called intraalveolar, right? So what happens is this will guide the eruption. This forms a stop, mesial stop, from where our first permanent molar is guided to erupt in its own location or space. Okay, so there is an important question that is usually asked. Okay, what should be the extension of this arm? What should be the extension of this vertical arm? Where it should rest? That is the main question. Very, very important question that is asked many a times. So where should the vertical arm rest? Can we keep it how much ever we want, or there is any specific dimensions we need to follow while we are placing or while we are fabricating it? So that is the question. So what should be the extension of the vertical arm of distal shoe appliance? Okay, come on, answer. Yes, as you all are telling, it should be 1 mm below the mesial marginal ridge. Suppose this is the mesial marginal ridge of the our first permanent molar. It should be 1 mm below the mesial marginal ridge. Okay, so not too short or not too long. It should be 1 mm below the mesial marginal ridge of a first permanent molar. That should be the extension. Okay, so generally the first appliance design is given by Willett, where it is bar type. So only a small extension he has given. Okay, whereas Roche has given a V-shaped extension to it, a V-shaped plate, so that the surface area is more. When we give only a small bar, there might be rotation of the permanent molar. So when we give a V-shaped bar-like extension, the surface area is more, and then it will straightly guide our permanent molar in its position. So right now, the appliance design we use is of Roche design. That is, we have a intraalveolar extension, which is a V-shaped plate. Okay, this is also very important to note. So distal shoe appliance, it's a fixed appliance, as you all can see. A passive appliance, which is the eruption guiding appliance, and the vertical arm should rest 1 mm below the mesial marginal ridge of first permanent molar. Okay. Oh, there is one more unique feature to this appliance. Can we give it in all patients, or there are some contraindications of this distal shoe? That is the next question. Any contraindications we have, or we can give it in any patients where this is the requirement. This is the case clinical scenario. Any contraindications? Yes, there are certain contraindications where you can't give this appliance, especially in the medically compromised patients. In case of CVS disorders, that is cardiovascular disorders, on congenital heart diseases, and also in case of diabetes mellitus, or also in special children that are physically and mentally handicapped who can't maintain it, we are not giving this appliance. In hemophilic patients especially, this is an absolute contraindication. Why? Why we can't give in specially able children this appliance is because of this extension, this intraalveolar extension which we are having. Because of this is not indicated where we have to cross the tissue barrier. We are crossing the tissue barrier, gingival barrier, right? So wherever there is a risk of infection, in such cases, we are not going to place this appliance. Okay, so medically compromised patients, generally it is better to avoid giving distal shoe. So that's all about distal shoe. I hope you all understood. So we can have a band like this on the abutment teeth, or we can use a crown also, to where we can solder this extension. The horizontal arm can be soldered even to a crown. Even for a band and loop space maintainers, if at all the abutment teeth is endodontically treated, we have a crown, we can directly solder the loop. In such cases, that is called as crown and loop, when we give a crown instead of a molar band. So here also for distal shoe, we can have the same thing. We can use a crown also instead of band. Okay. So this is all about our space maintainers. So we have covered band and loop, lingual arch, Nance palatal arch, transpalatal arch, and distal shoe. So hope you all understood this. So I know many of you know the names of this appliance, but it is very important to master the clinical rationale behind each appliance. In which case scenario we can use, there are any modifications that can be done, to fit into that particular case, where it should be given or where it should not be given. This is also important. The indication as well as the contraindication of each appliance is also utmost importance. So I hope this discussion has helped you to crack this clinical based questions, because every year there might be some 1 to 2 case based scenarios or one diagram based question that is usually asked in your MDS. Okay, So this way, this is the end of our discussion. We are ending. So for more content like this, do follow and do subscribe to our YouTube channel. And this is the code for our website, MDS Conquer website. And please do scan it. And we have an MDS Conquer app both for Android and iOS. So these are the codes. And here is our Telegram page, a free Telegram page where we'll be updating a lot of dental content and also daily quizzes. Exciting activities will be going on in a Telegram app too. And a very important announcement that we are going to make is our midterm course. We are coming with both online and offline midterm course that is starting from October 15th, where we are going to cover the entire syllabus before our exam. So please grab the opportunity and do come visit us and get subscribed to us. And here are the helpline numbers in case of any queries. Please do contact us. So that's all. Thank you.